goal of this presentation is to show you some clinical examples of several pathologies of the dorsal wrist in musculoskeletal ultrasound. All pathologies presented are exemplary and serve as practice for the pathology checklist. This is a left-right comparison of a transverse extensor tendon. The image on the left shows the healthy side, the image on the right the affected side. The shape of the retinaculum on the right has changed. See the increase in thickness compared to the healthy and very thin retinaculum on the left. The echogenicity of the retinaculum has changed. Due to the swelling, it has turned anechoic. The echogenicity of the tendon has also changed, a bit towards hypoechoic. There seems to be no problem in fibre continuity. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a mild tendinopathy and a tenor synovitis. This patient should be scanned in the other plane as well to double-check the pathology. Measurements of the tendon and retinaculum thickness and cross-sectional area have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a transverse scan of an extensor compartment of the wrist. The echogenicity within the tendon sheath, indicated by the yellow box, has turned anechoic. There seems to be no problem in fibre continuity. Based on this static image, it can't be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a tenor synovitis. This patient should be scanned in the other plane as well to double-check the pathology. Measurements of the tendon and retinaculum thickness and cross-sectional area have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This slide shows the fourth compartment of the wrist extensors. The left image shows a transverse scan of the compartment, the right image a longitudinal scan of one of the extensor tendons from the fourth compartment. This shape of the tendon sheath has changed. It shows moderately severe synovial thickening with no visible tendon sheath effusion, suggestive of chronic tenosynovitis. The extensor tendon shows synovial thickening extending along the dorsum of the hand with severe hyperemia, consistent with active chronic tenosynovitis. This is a serial sequence of transverse ultrasound images obtained from cranial to caudal over the distal dorsal forearm. The sequence demonstrates tenosynovial effusion in the sheath of the extensor carpi radialis longus and brevis at the level in which these tendons are crossed by the muscle bellies of the abductor pollicis longus and extensor pollicis brevis. The yellow dots in the images point out the increase of effusion in the compartment 2 tendon sheath, with, as a result, a change in echogenicity. There seems to be no problem in fibre continuity. Based on this static image, it can actually be confirmed that there is a functional problem, because previous findings suggest that this patient shows an intersection syndrome. This patient should be scanned in the other plane as well to double-check the pathology. Measurements of the tendon and retinaculum thickness and cross-sectional area have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a transverse scan of the second and third extensor compartment of the wrist. The sequence of images demonstrate the course of the extensor pollicis longus tendon relative to the Lister tubercle and the typical clepsydra-like distribution of sheath fluid in a case of tenosynovitis. The narrow tunnel of the third compartment intrinsically hinders the sheath distension of the extensor pollicis longus at the level of the Lister tubercle, except in cases of abundant effusion. Most often, the fluid distributes just proximal to the Lister tubercle, and after the tendon has crossed the extensor carpi radialis longus. This transverse scan of the extensor carpi ulnaris, compartment 6, shows that there is a change in fibre continuity and a change in function. The image shows an extensor carpi ulnaris instability during a progressive pronation of the forearm. When the wrist is supinated, ultrasound shows the groove on the ulnar cortex for the extensor carpi ulnaris tendon and an irregular appearance of the retinaculum. During progressive pronation, the extensor carpi ulnaris tendon subluxes over the internal wall of the groove. Note the flattened appearance, a change of shape, of the tendon as a result of tensile forces applied upon it. In full pronation, the extensor carpi ulnaris dislocates out of the groove and exhibits a more rounded appearance. An intact retinaculum maintains the extensor carpi ulnaris within the osteofibrous tunnel. A retinaculum tear leads the extensor carpi ulnaris first to sublux and then to dislocate out of the groove. This slide shows the necessity to scan proximal, distal at the distal radio-ulnar joint. Indicated in the yellow box shows the proximal recess distended by fluid as a result of a distal radio-ulnar joint synovitis. This is a dynamic scan of the scapholunate joint to observe a possible change in fibre continuity of the scapholunate ligament and to observe a change in the function of joint stability. The lower image shows the scapholunate joint under a stress by making an ulnar deviation. The upper image shows the joint in a neutral hand position. Note the absence of the scapholunate ligament, a clear sign of fibular disruption and a change in fibre continuity. See the increase of joint gapping and thus the passive instability during ulnar deviation. The goal of this presentation is to show you some clinical examples of several pathologies of the carpal tunnel in musculoskeletal ultrasound. All pathologies presented are exemplary and serve as practice for the pathology checklist. This is a longitudinal ultrasound image of the median nerve through the distal forearm and the wrist, displaying a carpal tunnel syndrome. Please note the change in shape. The median nerve has decreased in thickness in the distal carpal tunnel, here depicted within the red box. This thinning is a result of a compression of the median nerve. Most compressions on the median nerve occur in the distal carpal tunnel. If this is the case, the proximal carpal tunnel, in many cases, shows a thickening of the median nerve. This results in a change of echogenicity. Please note the difference in echogenicity in the affected region of interest in the yellow box compared to the echogenicity in the red box. The median nerve fibres in the red box are slightly more hyperechoic. This slide shows transverse ultrasound images obtained at the distal radius, just behind the transverse carpal ligament, at the proximal tunnel and at the distal tunnel, according to the reference diagram shown at the upper left side of the figure. Please observe the colour of the circular line around the median nerve's cross-section. This colour correlates with the colour of the transducer position indicated in the reference diagram. See the red median nerve. Progressive enlargement of the median nerve and hypoechoic changes in the epineurium occur just behind the proximal edge of the transverse carpal ligament. This is the point of maximum nerve swelling. Note the relationship of the nerve with the flexor pollicis longus and the flexor digitorum superficialis tendons. Always scan the median nerve more towards proximal and distal after having checked the carpal tunnel. Changes of the nerve may be very specific at one spot. This is a scan of the longitudinal median nerve. Please note the change in shape of the tendon sheath of the flexor tendon. The yellow line indicates clearly the increase in thickness. The median nerve is being pushed to superficial and squeezed because of this increase in thickness. The tendon sheath shows a change in echogenicity due to abnormally increased fluid effusion surrounding flexor tendons. Colour Doppler of the median nerve demonstrates blood flow signals from the longitudinal peroneural plexus and the internervous branches as a result of hyperemic changes related with the inflammation. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a carpal tunnel syndrome due to a compression on the median nerve at the entrance of the tunnel because of a tenosynovitis of a flexor tendon. This patient should be scanned in the other plane as well to double-check the pathology. Measurements of the nerve thickness, cross-sectional area and swelling have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a longitudinal ultrasound of the median nerve, showing a mild hourglass configuration due to compression within the carpal tunnel. This is a longitudinal ultrasound scan in a patient with carpal tunnel syndrome symptoms, showing a large, heterogeneous, oval-shaped tumour, continuous with the median nerve, just proximal to the carpal tunnel. The nerve immediately adjacent to the tumour is mildly thickened. Features are compatible with a large median nerve sheath tumour. The right image shows a longitudinal power Doppler ultrasound, showing moderate tumoral hyperemia with an irregular vascular pattern. This is consistent with a nerve sheath tumour. This transverse ultrasound scan of a patient with carpal tunnel syndrome shows thenar muscle atrophy on the left side compared to the transverse ultrasound of the contralateral side, showing the normal bulky thenar muscles. The left image clearly shows a change in shape and perhaps also in function.